بسم الله الرحمن الرحيم. Our lecture today about the elbow joint and the forearm. Overview. The elbow joint is a synovial end joint which incorporates the humeral-ulnar, humoradial, and superior radial ulnar joint. بالنسبة للhumeral-ulnar articulation, it is composed of the trochlea of the humerus and trochlear notch of the ulnar. The humoradial articulation composed of the capitellum and radial head, and allows both hinge and pivot motion. The radial ulnar, superior ulnar joint is composed of the radial head and the radial notch of the proximal ulnar. The articular surfaces of the elbow joint. نشوفهم بهاي الصورة. أول شيء عندنا الهيومرس. الهيومرس composed of two epicondyles, lateral and medial epicondyle, and the capitellum, the trochlea, and two notches, the conoid and the radial notch. بالنسبة للراديوس, it is the radial head articulated with the capitellum. The radial head articulated with the capitellum, and the ulna composed of two processes, the conoid process anteriorly and the obliconoid process posteriorly. And هاي conoid process. A joint capsule. A joint capsule attached to the margins of the articular surface of the radius and ulna, but more proximally on the humerus to include the obliquonon, conoid, and radial fossae within the joint. The development of elbow. At birth, the distal humerus is composed of single cartilaginous epiphyses, separated from the epiphyses by an arch. An injury at this time results in complete epiphyseal separation. The primitive epiphysis differentiates into four ossification centers: two epiphyses, the capitellum and the trochlea, and two apophyses, the medial and lateral epicondyles. Following such a division, subsequent injury is usually confined to individual ossification center, in contrast to the gross injury or displacement that occurs in infancy. The cartilage of the proximal ulna develops a single ossification center, the obliquonon, which eventually leads to the minimalization of the coronoid. The cartilage of the radial head develops into further single ossification center. The appearance of ossification center occurs 1 to 2 years earlier in girls than in boys, and follows an orderly progression. With the appearance of the capitellar ossification center first at 1 to 2 years, the radial head at 3 to 6 years, the inner or medial epicondyle at 4 years, the trochlea at 8 years, the obliquonon at 9 years, and the external epicondyle at 10 years. In adolescents, usually between 10 and 12 years, the three lateral ossification center fuse, followed by closure of their associated pieces at 13 to 16 years. The medial epicondyle pieces is the last to close at between 16 and 18 years. Inappropriate treated injury or to any of the ossification center around the elbow may lead to deformity. However, as the elbow pieces contribute to only 20% of final length, shortening is often subtle. عندي الجدول اللي وضح the appearance of ossification center. The capitellum at 1 to 2 years, the medial head 3 to 6 years, the medial epicondyle 4 years, the trochlea 8 years, obliquonon 9 years, lateral epicondyle 10 years. هذا اكو عندي فد نيمونيك يعني حتى واحد يقدر يحفظهن اللي هو كريتو يعني هم قربهن يعني الكابيتيلم يعني كابيتيلم راديال هيد الانترنال ابيكوندايل اللي هو الميديال والتروكليا والاوليكونال والاكسترنال ابيكوندايل اللي هو اللاترال. بلس سبلاي The blood supply of the elbow joint is by arterial anastomosis from the brachial artery and the radial artery and ulnar artery. Radiological features of the elbow joint. عندنا lateral X-ray view of the elbow joint. هنا واضح عندنا الهيومرس شافت السوبركوندايلر ريدج الكابيتولم radial head the tuberosity of the radius shaft الulna والtrochlear notch والاolecranon process. هنا هاي AP view of the joint. هذا عندي الميديال ابيكوندايل واللاترال ابيكوندايل. وايضا هذا عندي هنا الراديال هيد هنا والكابيتولم والتروكلير. The capsule of the elbow joint lags anteriorly and posteriorly so that fusion within the joint causes distension of the capsule anteriorly and posteriorly. Fat pads anterior and posterior to the joint are displaced away from the joint by an infusion and become visible as linear lucencies that are separated by soft tissue densities from the bones on lateral radiograph. Since the conoid fossa is shallow, the anterior fat pad can be identified in normality. In contrast, the olecranon fossa is deep, and therefore the posterior fat pad only becomes visible on lateral radiograph when elevated by intra-articular fluid or effusion. هاي عندي هنا هم صور الاكس راي الفات باد اللي هو قلنا يبين باللاترال راديوجراف وهذا انتيريور فات باد وايضا يسموها السيل ساين. سنحكي عن two radiographic lines that are important in X-ray اللي هو radio capitellar line. هذا radio capitellar line a line drawn down the neck of the radius and should intersect the capitella. والanterior humeral line هذا اللي هو line drawn along the anterior cortex of the humeral shaft is seen passing along the middle third of the capitellum. الأهمية ما بين اللاينات إنه مهمات to see supracondyle fracture. Arthrography. Arthrography of the elbow joint is achieved by injection of contrast medium between the radial head and the capitellum. The synovial cavity of the joint is outlined and seen to extend proximal to the articular surfaces on the humerus with a configuration on AP view that has been likened to rabbit ears أو يسموهن bugs bunny sign. هاي الbugs bunny sign يسموها. On lateral view, conoid recess is seen anterior to the lower humerus and an olecranon recess posterior. Distally, the synovial cavity is seen to extend anterior to the radius as the epiradial recess. This is indented where the annular ligament of the radius surround it. The elbow ligament. Now, the ulnar collateral ligament. The ulnar collateral ligament is responsible for the medial elbow joint stability and resistant to valgus strain. It is composed of three discrete tendons, tendon bundles: the anterior bundle, posterior bundle, and the transverse bundle. Despite anatomic complexity, the anterior bundle is most important contributor to the stability and therefore most frequently injured. The anterior bundle is entered in the extended elbow position and is therefore rarely visualized on direct coronal images, running from the undersurface of the medial epicondyle just deep to the common flexor tendon origin. Distally to its attachment, the medial aspect of the ulnar conoid process. Similar to other tendons with an organized structure, the ulnar collateral ligament is hypointense on all sequences. عندي هنا axial MRI هنا واضح عندي anterior bundle مالت الليجمنت، وهنا هذا posterior bundle. هنا واضحات عندي. أيضا الألنا collateral ligament tear يسموها تي ساين. هنا واضحة، هاي تي ساين. The lateral collateral ligament. Injury to the lateral radial collateral occurs less frequently than injury to the medial ulnar collateral ligament, complicating either acute varus stain or elbow dislocation. The lateral collateral ligament has four components. The radial collateral ligament, which is primarily responsible for the lateral joint line stability. The lateral ulnar collateral ligament, which is primarily responsible for the posterior lateral stability. وأيضا عندي الانnular and accessory annular ligaments responsible for the stability of the proximal radio-ulnar joint. At MRI imaging, the radial collateral ligament being taught throughout elbow flexion is clearly identified on coronal images at approximately the same level as the anterior collateral ligament, anterior bundle of the collateral ligament. The lateral ulnar collateral ligament is identified on posterior coronal images being obliquely oriented, running from the lateral epicondyle to the posterior lateral aspect of the ulna. It is identified on serial images and stored when varus strain is applied. The annular ligament injury in which should be suspected in patients with either acute or repeated radial head subluxation or dislocation are best visualized in axial plane, similar to the ulnar collateral ligament. Injury range from subtle signal abnormality through the peritendinous edema to complete tendon disruption. أيضا صورة مع وضع عندنا collateral ligament. annular ligament واضح عندي. lateral collateral ligament tear. هذا عندها partial tear. هنا عندي complete tear. A radial collateral ligament injury, because it often reflects long-term overuse, is commonly accompanied by extensor tendon injury. Epicondylitis or tennis elbow, most frequently accompanied by partial tear of the extensor carpi radialis brevis. The muscles around elbow and forearm. The elbow muscles can be classified in four groups. الانتيريور جروب اللي هي تشمل البركيالوس والبايسبس. البوستيريور تشمل الترايسبس والاكونيوس muscle. الميديال تشمل البرونيتال تيرس، flexor carpi radialis، palmaris longus، flexor digitorum superficialis، وflexor carpi ulnaris. اللاترال اللي هي تشمل البركيو radialis، extensor carpi radialis longus، extensor carpi radialis brevis، والاكستنسor digitorum communis، والاكستنسor digiti minimi، and the extensor carpi ulnaris. أنا أخذ مخطط يعني وضع المصوص. هاي flexor carpi radialis، البركيو radialis هنا أيضا. إذا بقيت الأعضاء. هنا axial MRI scan through the forearm. هنا عند external carpi radialis muscle هنا واضحة، وأنا هاي external carpi ulnaris، external extensor digitorum muscle، extensor pollicis longus muscle، والabductor pollicis longus muscle هنا هذه. هنا هاي عندي flexor carpi ulnaris muscle، هاي flexor carpi radialis muscle، هاي flexor digitorum superficialis، وهاي رقم 11 flexor digitorum profundus. هاي هنا عندي هاي فكرة جالس مصل. The biceps muscle and tendons. The biceps brachial muscle is composed of a long head and short head. The two muscle bellies share a single tendon insertion on the bicipital tuberosity of the radius. The short head arises from the apex of the coracoid. The long head arises from the supraglenoid tubercle of the scapula. Injury involving the biceps muscle more frequently involves the tendon that the muscle, uh, the injury involves the tendons down the muscle bellies. And of the tendons most frequently affect the tendon of the long head injury to the distal biceps tendon. And when it is occurs, it's usually secondary to acute macro trauma or overload, occurring attempting to carry a heavy object in such way. Attempted elbow flexion through the biceps tendon is counterposed by a force extension induced by the object. The resulting tear occurs most frequently at or just proximal to the tendon insertion on the radial tuberosity. The distal biceps tendon is best visualized on the axial and sagittal plane. The axial image is clearly depicting the normal insertion site on the radial tuberosity. The sagittal image is allowing an appreciation of the extent of the retraction. Although biceps tendon injury is usually clinically apparent, manifest as an obvious mass, compensatory flexion incurred by the brachialis may obscure the diagnosis. The triceps tendon muscle uh, the triceps muscle lies in the posterior compartment of the arm and is composed of three heads. The long head arising from the infraglenoid tubercle, the lateral head arising from the lateral and posterior aspect of the humerus, and the medial head arising distally from the medial and posterior aspect of the humerus. The three heads unit to form the tricep tendon in the mid-arm. The tendon being composed of dominant deep component which merges with the superficial component before inserting on the posterior superior surface of the olecranon. Triceps tendon injury is extremely uncommon and must frequently occur secondary to forced flexion against a contracted muscle. As occurs following a fall on the outstretched hand, rarely injury may follow a direct blow or complicate olecranon parasitis, where steroid injection, synovitis, and superimposed infection conspire to weaken the tendon. In most cases, the tear of the distal triceps tendon is complete and associated with avulsion of small fragment of bone from the posterior aspect of the olecranon, rarely visualized on conventional radiographs. Rupture of the muscle belly or at the myotendinous junction in the absence of an avulsion extremely uncommon. نيجي موضوع الابيكوندايلايتس. الفيرست lateral epicondylitis or tennis elbow is the common cause of elbow pain in adult population. The term epicondylitis is misleading as the disorder is characterized by soft tissue changes in the absence of epicondylar bony edema or inflammation. It is thought to reflect degeneration and tearing of the common extensor tendon as a result of chronic microtrauma secondary to traction forces. As it is most frequently identified in athletes. Dissected specimens show fibrillary, hyaline, and myxoid degeneration with angiofibroblastic proliferation within the tendon, or origin and minimal associated inflammatory changes. هنا عندي صورة MRI للتنس الباء أو lateral epicondylitis اللي هو عبارة عن soft tissue changes راح تصير على المكان. Medial epicondylitis or golfer elbow is considerably less common than the lateral epicondylitis. Like lateral epicondylitis, the term is misleading as the injury is primarily to the common flexor tendon rather than to the underlying bone. Repetitive valgal stress at the elbow and overhead games or in golfers and adolescent result in chronic microtrauma to the common flexor tendon, with the secondary degenerative changes, breakdown inflammation of the flexor carpi ulnaris within the cubital tunnel may lead to secondary ulnar nerve compression. نجي لموضوع السودو regions of the elbow. Pseudo defect of the capitellum على أول واحد. In the normal elbow, there is an apparent osteochondral abnormality, often mistaken as being due to Banner's disease. In the sagittal plane, along the posterior half of the perceived articular surface of the capitellum, in cadaveric specimen, has been shown to present junction of the capitellum and lateral epicondyle. ثاني شيء عندي pseudo defect of the trochlear groove and ridge. The junction of the coronoid and olecranon is marked by ridge 3 to 5 millimeter thick, devoid of overlying cartilage, routinely identified on sagittal images of the elbow, traversing the joint space. At this junction, the bone extends to oppose the surface created by articular cartilage, ridge, occasionally not quite to the level of the articular cartilage, but never beyond. At the far medial and lateral margins of the ridge, the bone tears to form marginal grooves. ثالثا عندي lateral synovial fringe or meniscus. A triangular circumferential marginal fold of the capsule and synovium is interposed between the radial head and the capitellum and the normal elbow. It may become more prominent in patients with Banner's disease, secondary to friction, and caused by irregular articular surfaces, or in patients with inflammatory arthritis. The skin thickening over the extensor surface of the elbow. The skin overlying the olecranon appears thickened on MR images as a result of porosity of the underlying subcutaneous fat, particularly on images acquired in the sagittal plane. Distal triceps tendon signal heterogeneity. In the axial plane, the fibers of the distal triceps are loosely packed, resulting in signal heterogeneity in the axial plane, even in health. And in the hyperextended position, the sagittal images show triceps tendon laxity and fault, which should not be mistaken for partial tears. عندي موضوع neuroanatomy and injury following elbow trauma. Elbow trauma may lead to the injury of the median nerve within the anterior medial soft tissue, most frequently following anterior dislocation, or injury to the radial nerve anterior to the lateral epicondyle, most frequently following lateral epicondyle fracture, or to the ulnar nerve within the cubital tunnel, immediately posterior to the medial epicondyle. Intimately related to the medial epicondyle, the ulnar nerve is most frequently injured nerve about the elbow. Direct impaction leading to nerve contusion, fracture, resulting in nerve compression or traction, and muscle or ligament tear, allowing nerve subluxation, may all lead to reversible nerve deficit.
عاشت ايدك دكتور علي. يلا حسنى عيني ايه مبينه. حسنى رقم اشر لهم انت رقم 1. حسنى حسنى وين راحت؟
حسنى بلي العفو دكتور. radial collateral ligament number 1.
This is the radial collateral ligament. Excellent. زين. حسنى.
نعم دكتور. This is radial head with surrounding annular ligaments.
Radial head. Excellent. نقدر نقول هذا يا الليفت لو الرايت؟
عمو هو حسب الصورة اللي ماخذيها إنه الراديال هيد صاير يعني من هاي الجهة، فعلى الأغلب هاي الليفت سايد. الليفت سايد لأنه عمو دا تشوف من جهة إحنا بالباوربوينت ماخذين الراديال هيد صاير على جهة الرايت سايد مال الشاشة مالتنا، فهم ماخذين الليفت هاند.
حوراء. 3
coordinate
neck of the صوت ده يقطع.
طلعت الإجابة، ما سمعت الإجابة.
ما سمعنا أني همين. ناخذ مروة أمين. مروة نمبر 3.
نعم دكتور.
مروة.
نعم دكتور.
نمبر
نعم
3
دكتور.
بقى.
دكتور supinator muscle supinator muscle.
supinator muscle belly. excellent. نختار إبراهيم نمبر 4. ده يشير لك عليها.
نمبر 4 هو الالنر كولاترال ليجامنت.
ulnar collateral ligament. يوسف نمبر 5.
نعم أستاذ. الميديال ابيكوندايل هذا.
medial epicondyle. دكتور علي.
نعم أستاذ. نمبر 6 كورونويد فوسا.
كورونويد فوسا ودي زين.
supinator muscle belt.
اوكي جاوبوها بنتي ماكو مشكله. حسن حيدر.
نعم أستاذ. نمبر 7 هو الكورونويد بروسيس.
كورونويد بروسيس اوف دي يابون
الله.
اوف دي النا. اكسلنت. لازم تكمل هاي. زينب سعيد بابا نمبر 8.
نمبر 8 extensor digitorum muscle belly.
نسد ديجيتال. بقت عندنا 9 و10. زينب سعيد. زينب.
نمبر 9
ايه
flexor carpi radialis muscle.
اكسلنت. واخير واحده نور محمد نمبر 10.
ألو.
نور.
pronator
تفضل.
teres.
برونيتر تيرس. اكسلنت. عندك
سؤال
بعد؟
واحد. سؤال
يلا
واحد بس
استاذ
يعني
محمد. تفضل استاذ محمد.
نعم استاذ.
تقول فوز احنا خلاص يا فوز.
يوسف.
نعم أستاذ.
يلا.
The capitulum articulate with the ulna. False. The capitulum articulate with the radius.
نعم. جيد. مهند جواد. مهند.
نعم أستاذ.
نعم.
The annular ligament of the elbow blends with the ulnar collateral ligament. Falls with the blend with the radial collateral ligament.
نعم. سالي سي.
C, the capitulum is the first secondary ossification center to appear in the elbow. True.
نعم. رؤى جبار.
A prominent posterior fat pad in lateral radiograph of elbow is seen in cases of joint fusion. True.
عايشة ايدك دكتور